Hey everyone, my name's Jess. Today I'll be hosting today's session, Pain Theory and Practice. Thanks all for coming from your busy work schedules and coming from a variety of different musculoskeletal settings. You can see that we've got lots of different disciplines in the room. My name's Jess. I've been working in private practice for a long time. We want to make this session as interactive as possible. So please, you can see that we've got you set up in a semicircle. It's quite informal. A few of you guys are sitting on the ground. I'm also mindful everyone's got a whiteboard marker and there's some whiteboards or some butcher's paper on the ground. So we'll be using different tools throughout the session to deepen your understanding of what we're going to be talking about. So we're going to cover three main core principles, and we'll come back to these at the end of the session. And this is what I want you to really take away from today's talk. Number one, pain is complex. Two, a deeper understanding of a topic makes you a better educator. And number three, better education leads to better client outcomes. Which is why we're all here, I think. So let's dive into the first two concepts. Pain is complex, and let's deepen our understanding of pain. Now, I'm really curious. Please shout out. I've got the whiteboard behind me. What theories did you learn about pain when you were at uni? Great. Yep. So I've heard some different ideas there. Pain gate theory might have been one. It's great to hear that. I heard lots about the biopsychosocial approach to pain. And that's where we're going to really dive into these modern pain theories. I've got a definition here of pain, courtesy of Lorimer Moseley. I want you guys just to take a bit of time to read that. I don't know how that landed for a lot of people, but this is what we're going to be talking about today and exploring more. That pain is an unpleasant conscious experience that emerges from the brain when the sum of all the available information suggests that you need to protect a particular part of your body type. So we're going to really jump into the pain mechanisms model and understand and unpack how this might actually happen in real time with our clients. Now, to keep this really practical, I want you to have in the back of your mind or bring to mind a client that you saw this week that you might be able to apply some of this information to. So this is the model. You'll gain resources at the end of the session with references, but this is kind of the image that we use when we're talking pain mechanisms model. So we're going to unpack each stage. So the first thing is an input. We know that there's not a pain nerve in the body, but instead we're getting or sampling input from lots of different places within the tissue. So let's really think about what they are. Does anyone want to raise their hand? Yes, so we've got free nerve endings, which are A and delta C fibers, nociceptors around the nerve root. So they will collect information. It might be mechanical in nature, it might be temperature, it might be chemical, could be vibration. So there's lots of different inputs that those free nerve endings are collecting. When there's enough information or input, we'll have an action potential, and you can see here that if there's enough information, bang, we get this message, and then it will send or open up those ion gate channels to the next area or input, which, if we look back into this slide, will be our dorsal horn. Once we get enough information there, and these might come from our immune cells, inotropic receptors from those C fiber nociceptors, we get these graded action potentials transmitting these danger signals up to the secondary neuron, dorsal horn, and then it goes whoop straight into our brain. Now, these ion channels can be influenced, and this threshold here can be lower if there's a higher resting membrane potential at the actual site. So if there's inflammatory soup there, then instead of there being lots of information to open those ion gate channels, there might only need to be a little bit of input to open those ion gate channels. We'll come back to why that might be important in future, but I just want you to know that that sensitivity can be up or down regulated depending on what's happening at a tissue level. Once those messages go up through the dorsal horn, spinal cord, and then into the brain, this is when a lot of the magic happens, and we call this the scrutinization stage of the model. Really, what our brain is trying to decide is how dangerous is this information? So, can you guys think what factors influence this? Great. We had some great suggestions that we put on the whiteboard. Yes, past experiences, people's beliefs, knowledge, their environment. If you're being chased by a tiger, for example, that might influence how you're going to perceive pain. Your past behaviors and what was successful for you in the past. And also cultural context can also be really a key factor here. So there's lots of different inputs that make this scrutinization point to then decide, hey, how dangerous is this information? Do I need to worry, or is it fine? Once our brain decides this, we then have an output. Now, the output is kind of broken down into three main things. Our body then decides, given how much credible evidence of danger there is, what behaviors do I need to change to protect myself? What are my perceptions that might need to change, again, to protect myself? And what needs to happen from a tissue level, again, to protect my body from this impeding threat? So, perceptual and emotional responses. We could, if there is enough credible evidence that there's a threat, we could have fear, frustration, anxiety. These are all really common when it comes to pain. We'll have different behavioral responses, and I am glad that you guys raised some of those. Yes, what is it like? Think of some of the weird things you've seen clients do or move when they're coming in when they are in pain. Yes, great example there, Daniel. We've got some breath holding, people really rigid, quite fearful to move. They might be grimacing a lot, lots of moaning. They might be having lots of distress, depending on how much that perception of threat is. So again, there's lots of different factors that will affect the output. And then here we can have some physiological responses. So if the brain decides that there is enough credible evidence for danger, out comes the drug cabinet from the brain. We increase our heart rate. We might get some neurogenic inflammation, axonal releases triggered, like things like substance P, glutamate release. All of this then not only helps the tissue heal, but it does also prime the tissue to have increased inflammation levels, and those ion channels at those tissue levels then become a little bit more sensitized because they might not need as much information then to turn on to send the extra signals back up to the brain. So you're right, it is not linear. All of this happens at the same time within the same really quite quickly. So our body is amazing. When we resample or re-scrutinize, this can be helpful or it can be harmful. So we can increase fear, which might increase our pain sensitivity, change our behaviors, increase our physiological response to our perceived threat, and increase that pain loop. It can become quite maladaptive. I did hear some of you guys talking about catastrophization and altered movement patterns. And then this is distress that can reinforce that cycle of pain. Now, we're going to break out into groups now, and I want you to play. So we're going to think about all these different inputs, scrutinizing, and then output. And I want you to break down bring to mind that experience of that tricky client that came in today. And on your butcher's paper or whiteboard, I want you to write down all the different things, factors first, the inputs that they might have been experiencing, how their scrutinization might have then changed that perception of threat, and then what their output was. Fantastic, guys. That was really great to see you all collaborating. So, we're going to just finish off or round out this portion of the talk, going back to those core principles. Number one, I think we've really unpacked how complex pain is. I can already see that you've got a deeper understanding of the topic, which again, we're thinking is going to make you a better educator. And that then, even just by talking to each other, I could hear that better education, we can assume, then leads to better client outcomes.